which is going to segue nicely to Jake Kempton, who's going to talk to you about TPAs and employers and how they can best serve your patients. So thank you.
Megan had introduced me a minute ago while waiting on the slides to line up, and I'm Jake Kempton. I'm the co-founder of the Free Market Medical Association along with Dr. Keith Smith. That's kind of my hobby. My day job, though, is I actually run and own and run a independent third-party administration company in Oklahoma City called the Kempton Group. And normally, I would be giving you all a speech on the concepts of the free market and the concepts of direct primary care. Chris did a great job of talking about that, but you all have also had a lot of amazing speakers already this morning that have talked about that. So I don't feel like, last year, Lee, when we were speaking, it was like a lot of wide eyes. I can see that we've got some true believers. So I'm going to actually talk to you all a little bit of a topic that's kind of off the beaten path for me. In fact, our attorney back at the TPA is probably sitting there rubbing on a rabbit's foot saying, Jay, don't screw this up, because I'm going to be talking about some legal issues and some tax issues that have to do with your business, have to do with direct primary care and how you all interact with self-funded employers and employers in general. So not as sexy a topic as some others, but I think it's important for you all to hear it. First off, kind of the good news or the great news is that direct primary care is an incredible benefit for the employees out there. I've talked about in other sessions that the goal of an employer is to have the goal of their benefit plan really is to have happy, healthy employees that show up on time, don't complain about their illnesses, aren't worried about a sick child at home, et cetera. And direct primary care is probably the best vehicle to end up with happy, healthy employees. It's also one of the best ways to achieve happy and healthy employees at one of the most cost-effective methods as well. In my business, in the benefits business, return on investment, ROI, is always what we hear. Every program that a benefit administrator or a benefits consultant puts out there, always talking about ROI this, ROI that. If I put in $1, how many cents is that going to save me? And really, return on investment, if an employer is investing in direct primary care, the greatest probability that that employer is going to see an actual return on their investment if they choose to assist in the payment of a direct primary care fee is going to be if that employer is self-insured. I'm not saying that it's not a good idea for an employer that maybe has a small group Blue Cross policy or Aetna policy, but you all understand that if you keep those employees happy, healthy, you keep them from going up to the low efficiency hospital systems, that's going to save money, right? However, it's going to save money back to that insurance carrier. And with small employers that are fully insured with an insurance policy, there really is not much of a mechanism in place. In many, many states around the country, there's what's known as community rating that is in place. And all that means is if you're a 14-life employer in Dubuque, Montana, and you have a fully insured policy and you are healthier than another employer across the street from you, and you have less claims, you may not be paying less in insurance premium because you are part of a big pool within that insurance carrier. And so there is no direct relationship between having healthier employees, lower risk employees. That does not automatically translate into paying less insurance premium. So there's a disconnect on that return on investment between direct primary care and lowering the cost of an insurance plan. But on a self-funded plan, where the employer is paying for their employees' medical bills directly out of their revenues, if you all doing what you all do best, if you all are able to either keep them healthy, keep them out of the large hospital, or because your great negotiation skills that were talked about at the last session, if you're able to negotiate a $500 MRI instead of a $4,000 MRI, that delta, that difference in cost for that MRI it falls right to the bottom line of that self-funded employer, because they're paying all of the expenses right out of their revenue. So a dollar that is not spent is a dollar that stays at the employer. You don't have to rely on an insurance company to, in their good graces, somehow give you a return with a lower insurance renewal at the end of the year. Also, less absenteeism. That's something that from a benefits perspective, direct primary care, the access of care and the availability of care, whether it's in person or telephonically, that's another huge benefit of direct primary care to an employer. Self-funded, I already mentioned about this, but self-funded employers, they experience reduced claims. And if they experience reduced claims, that translates into direct reduction in the cost of their benefit plan. And those reductions in cost to the benefit plan can be used to maintain a very rich and comprehensive benefit plan that does not shift additional out-of-pocket expenses onto the employees. Unfortunately, in the benefits industry, until the free market kind of started to happen a few years ago, one of the only tools in the toolbox for saving an employer money, and you all have been the victims of this for years, was to increase deductibles, increase out-of-pocket maximums, which we weren't saving money at all, were we? We were just shifting those dollars, those expenditures from the benefit plan onto the patient, which they were many times ill-equipped to absorb, and that translated into bad debt for the medical community. Direct primary care enables an employer to save those dollars, keep the benefit plan rich, and you don't end up with that spiral of cost shifting. Also, direct primary care is free market friendly, but it doesn't funnel patients upstream to the more inefficient places of care. Chris did a great job of explaining the discounts, the charge master minus a 50% discount. Boy, what a great deal we got. But no one's watching that charge master amount. The only thing that really makes sense is to start indexing that stuff to cash, and you all are the ones that are equipped to find the upstream, the tertiary care medical providers that are very highly efficient. They are low cost, they are high quality, and if the direct primary care can basically insert themselves in and break that corporate hospital referral chain, that is a huge, huge cost savings and huge benefit to that self-funded employer. So those are all the good things about DPC. Now, one of my least favorite topics is government intervention and regulation, but this is kind of where my speech kind of starts going into the dark side a little bit. An employer, when they're doing business with direct primary care, they need to be very careful of the regulations that are in place right now. I have a slide. The next slide actually says it. I'm going to say it now, though. The regulations at the Department of Labor and at the IRS have not caught up with what we're doing. They have no concept when those regulations were written about the idea of direct primary care or bundled cash pricing for surgeries. Their universe right now is focused on the status quo. Everything is, if you've ever been unfortunate enough to read Obamacare, everything talks about in-network this, in-network that. Like somehow if you utilize in-network medical providers, that is going to be an automatic, high-quality, low-cost solution. So bear in mind as we talk through this that if the regulations catch up, my presentation from here on out may just be completely irrelevant, which I hope it does become that way. The Trump administration is certainly making some changes. They seem to be making some nods towards a more free market friendly attitude. I know that there are those of you in the room. I know Dr. Umber has been to DC a few times. Hopefully he didn't let any of that swamp water soak in. But it is on the radar about what direct primary care is, and I know there are a lot of politicians that are trying to craft essentially enabling legislation that will make the things that I'm getting ready to talk about a non-event. But right now, today, at whatever time it is, 11:10, these are concerns, so we're going to step through them. First, if an employee is enrolled in a qualified high-deductible health plan, also known as an HDHP, and they have an HSA, a health savings account, and in order for a patient to make contributions to a health savings account, the feds mandate that they must be enrolled in a qualified high-deductible health plan. So what? What does that mean to us? Well, what it means to us, unfortunately, as DPC providers, is the way the regs are written right now, before a patient that is enrolled in a qualified high-deductible health plan can receive any benefits except for a very narrowly written, narrowly defined array of preventative-only benefits. In other words, in absence of a diagnosis, certain screenings, et cetera. But if they receive any benefits outside of these screening type of procedures, then that will disqualify them from being able to make contributions to that health savings account. It basically undoes the reason why they're actually in the health savings account high deductible health plan in the first place. That's a big problem. It makes no sense if you think about a health savings account and a qualified high deductible health plan. Those were invented in order to create better consumers. If those of y'all that pay attention to that remember, right? That was the whole pitch. Well, some of the most innovative consumer-driven concepts like DPC unqualify you from being a member, being able to contribute to your health savings account. The employee may be put into an adverse tax situation, and it doesn't matter who pays for the DPC membership. It doesn't matter if it's the employee or the employer. The flat-out benefit, the bottom line is if that employee is involved in any type of an arrangement that provides them benefits before they meet that deductible, that is an unqualifying event. In my world, we do a lot with direct primary care, but we also do a lot, we have relationships with about 80 free market medical providers, surgery centers, imaging centers, et cetera. We call those Kempton premier providers, and it was really modeled after Keith Smith. But they're all over the country, and the way that we do business with those folks is right in line with the FMMA pillars, as you can imagine. But we waive the patient's deductible, copay, co-insurance, and the self-funded employer just writes a check for the surgery, and we usually get those funds back to the surgery center within about 5 business days. We are not able to do that if the patient or if the employer has one of these qualified high deductible health plans. And it's the same reason why it's a problem for DPC. Because by waiving that deductible and allowing Sally Sue to have that bunionectomy without meeting that deductible, by waiving the deductible, that will unqualify her for her health savings account. So don't think it's just picking on direct primary care. Hopefully this will change. Everything, different initiatives that are in DC right now do seek to fix this, but not yet. Okay, again, talking about IRS, Internal Revenue Code provisions is close to getting a root canal for me, but again, I think it's important for you all to hear it. If you all have ever thought, you probably haven't, but if you've ever thought about the entire concept of benefits that are provided by an employer, when an employer has a self-funded benefit plan or buys a Blue Cross and Blue Shield policy for their employees, that is a tax-free benefit that the employer is providing to the employee. It is not seen as taxable income. Why? Because of Section 104 and Section 105 of the Internal Revenue Code. That is the code sections that allow an employer to offer benefits on a tax-free basis to their employees. In Section 213 of the Internal Revenue Code, it actually describes the specific deductible medical expenses. So here's the concept that you can provide benefits that are not taxable. And then in 213, it tells you what benefits you can provide that are qualified to be non-taxable. It is an actual list. One of the things that is excluded from being tax exempt are membership fees, access fees, if you will. On my next bullet, I say the IRS is not caught up with the marketplace. Concierge medicine is considered access. Does everybody know what I'm talking about when I say concierge medicine? It's not you. Concierge medicine predates DPC by a lot of years. You know, probably the main concierge medicine practice out there is MD-VIP. And their model, by and large, is that the docs can provide a higher level of care, a higher level of attention, because they're going to reduce their panel from 4,000 down to 600 or 400 or some much smaller number. And the way that they're going to be able to do that under MD-VIP is that MD-VIP is going to create an access fee where the patient is asked to pay $2,000 a year, for instance, for the privilege of being that physician's patient. You are essentially a VIP for that physician because he's only going to do business with a select few employees that have paid for the privilege of being that patient. Now, when you go and see your MD-VIP physician, unless they've changed it, what they're doing after you see that patient, they will say, well, who's your insurance with? Well, I'm with Blue Cross and Blue Shield. Okay, well, I see that's a $25 copay. They're an in-network medical provider, and they bill insurance just like they used to. So when they're billing insurance, they're billing the insurance plan for the care, but the employee or the patient is paying the access fee to access the privilege of being a patient in order to receive the care. The IRS looks at that access fee as something that is specifically excluded and is not a qualified tax-exempt medical expense under Section 213. So, for those of that spent the night in a Holiday Inn Express, you can probably draw the line into where the regulators are having an issue with DPC. Because they see a DPC, when we talk about a DPC membership, which I've said it, when they hear membership, they immediately think, oh, this is like concierge medicine. In fact, this is something that drives Megan crazy at the Free Market Medical Association, is that we have some DPCs that will interchangeably refer to them as concierge medicine. That's what's got to break. The distinction has got to be created in the IRS and the regulator's mind that direct primary care fees are for care. They're not for a membership fee in which you then subsequently get charged additional for the care. The membership fee is for the care, and in our opinion is thereby permissible under Section 213. They don't see it like that yet. I hope this is helpful to you all. I'm trying to break down something that's very, very complex and something that's relatively simple, but I think it's important for you all to understand why is this insanity out there. And it's still insane, but this is partially why. So again, your language, word choice is very important. We do not ever want to be seen as concierge medicine as it is known and defined by the IRS. Okay, so now I'm going to give you all a couple of scenarios. We've talked about the things that we have to watch out for, but is there a proper way for an employer to provide assistance with paying the membership fees for a DPC membership for their employees? Yeah, there is. There's several ways that you can do this. The one that we recommend at the FMMA and also at the Kempton Group is by doing it through an integrated health reimbursement account. And this is something that the employer can choose to sponsor, choose to add to their benefit plan. And this example, this slide, it assumes that the employer does have a health plan. So they already have a health plan. We're assuming it is already fulfills all the Obamacare regulations and rules. And they want to add DPC, and they want to incentivize their employees to use DPC. And so they're going to offer some sort of a monetary assistance with the membership fee. The way that they would do it would be to come up with a health reimbursement account. And when I say integrated health reimbursement account, that's important. They already have a health plan, and when they sponsor an additional plan, health plan, a health reimbursement account, it's important that this health reimbursement account is a very, very limited scope health reimbursement account. In other words, all of the Obamacare provisions that where we're going to make sure that we're in compliance, that's all being done by the health plan. The HRA is simply brought in to just supply the fees that go to the DPC. Best way to explain this is using myself. The Kempton Group is a great example. We have 45 employees. We're self-insured. We love DPC, so we wanted to offer DPC to our employees. The way that we did it, we put together a limited scope HRA. We don't even have an administrator administer it for us. We actually have our accounting department administer it for us. Simply requires a plan document, be written by a professional. But the way it works is when my employees, if they have a direct primary care membership, and that relationship is purely between the employee and their DPC, they bring in a receipt showing me that they have paid their DPC membership for the month. We get that, and then we reimburse them up to $75 for that membership every month. And they just have to bring us that invoice every month showing us that, yep, I still have a DPC membership. I don't really care who they have it with. They can change DPCs, but that's how they get access to that tax-free reimbursement. We also have to document, though, at our company that those employees are actually receiving care from their DPC. Because on a previous slide, we can't, if the IRS was ever to look at the Kempton Group, well, Kempton, why are you paying this employee $75 a month, but you're not holding taxes out of it? Well, because it's for a DPC membership. I mean, it's for DPC care. We have to be able to document that that employee has actually received care from the direct primary care physician. If we're paying a membership fee, but the patient never texts their doctor, they never go see their doctor, they never have a phone call with their doctor, as an employer, I cannot respond to that IRS auditor that I was paying for care. But I see here that Sally never went to the doctor. So now what was that $75 a month again for? It starts to look like access. Now there's several DPCs that I've talked with that are doing a great job of documenting the care that's provided to be able to report back to a TPA or to an employer. This is the reason why. It gets back to those previous slides where the difference between care and access. Care is good, access alone is not a tax exempt expense. I hope I'm making sense here. I can't find, I see, okay, thank you, sir. I see some heads nod. I have to have that feedback. Okay, so that was the example of an employer with, well, I'll back up one. The other reason why we recommend doing this under a health reimbursement account, because you could just integrate direct primary care membership fees or fees, you could just add that as part of your benefit plan. We pay for the sniffles, we pay for heart attacks, and we pay for direct primary care, all under your health plan, your regular health plan, and not have an HRA, a limited scope HRA. The reason that we recommend the limited scope HRA, I gave you several reasons, but the first bullet there is if the IRS was ever to have a question about this access versus care thing, and they found out that the plan was somehow out of compliance because you were incorrectly paying for access and not care because the employees didn't use the plan and they disqualified your plan, they disqualify the little limited scope health reimbursement account. And it firewalls the main health plan. The HRA is this little baby nothing. The big health plan, we're talking big, big dollars, big, big exposure to the employer. I'm glad I caught that. I would have been wishing I had said that when I was on the plane. Okay, small employers with no health plan. We hear a lot of this from the Free Market Medical Association switchboard. We get a lot of employers, or excuse me, DPC docs that will ask this question, and they don't like our answer. And we don't like our answer either, but it doesn't change the fact that it's the answer. And this is, if you've got a small employer that they have chosen that they cannot afford to offer a group health plan, and they don't have to under Obamacare. So they're just not going to have a health plan, and they're maybe going to give their employees a raise and let the employees go out and buy their own plans on the exchange. That's fine. That's perfectly permissible. But then when their friendly neighborhood direct primary care doc comes and sees them and talks about all the wonderful things that DPC does, and this employer is thinking, well, I don't even offer a health plan. DPC would be a great benefit. Something I could do for my employees that is great. It's going to keep them happy. It's going to keep them healthy. And I can actually afford to do this. And then they come up and they say, well, how do I do this on a tax-exempt basis? Well, you need to have a health reimbursement account. Yep, that's all good advice. The problem with that is if the employer does not offer a health plan already, and they offer a health reimbursement account, the IRS can come in and look at that health reimbursement account that is, only thing that employer is using it for is to provide DPC membership fees. But the IRS could interpret that nope, you have a health plan. You said you didn't have one before, but now you do, but it does not comply with all of the Obamacare mandates. Certainly that was not the intent of the employer. The intent of the employer is they just wanted to add a little bit. But when they added a little bit, the IRS looks at a health reimbursement account. It is a health plan. It's just important that you don't want it to be seen as the health plan. You want to see it as integrated onto an existing plan. And the ramifications of offering a health plan that does not meet all of the Obamacare qualifications. You don't have to offer one, but if you do, it better meet the qualifications. But if you don't do that, what you end up with is a non-compliant plan. Now, a non-compliant plan, anybody heard of Hobby Lobby? Okay. I don't know if you ever saw the big, gigantic numbers when they were talking about the fines. It was going to put Hobby Lobby out of business. And the reason is because they offered a health plan, and it did not meet all of the Obamacare requirements. They had a problem with certain birth control provisions. And so their plan was going to be deemed a non-compliant plan. Anybody want to know what the fine is if you were deemed a non-compliant plan? It's $100 a day per employee. It's a death sentence, so you don't want to do that. So the reason I want you all to know this is, again, for that benevolent employer, they would be very, very tempted to do this. We don't want them to do this. We don't want them to get their head cut off because they were trying to do the right thing for their employee. Hopefully, the IRS regs will catch up with this. There still is a way that small employer, that benevolent employer, can offer and assist with the DPC membership fees, though. They just have to do it as a taxable benefit. That's the way you do it. Don't need an HRA, don't need to hire a professional or anything else. Just flat out pay it, and it's just a taxable. You just gave them a little bit of a raise to pay for their DPC membership. That's the get out of jail free card. Thank y'all very much.